we have Dr. Rachel Coakley joining us today for our CHEAR seminar this morning. I got to work a little bit with her back when I was in grad school in Houston, and I'm familiar with her work, and I think this is going to be a really, really great session for all of us. So I'll go ahead and get started by just briefly reading through Dr. Coakley's bio, and then I will hand it over to her, and then she can move forward with her presentation. So Dr. Rachel Coakley is a pediatric pain psychologist in the Department of Anesthesia, Critical Care, and Pain Medicine at Boston Children's Hospital, where she serves as the Director of Clinical Innovation and Outreach in the Pain Medicine and the Associate Director of Psychological Services. Additionally, she is founder of the Director of the Comfort Ability Program, which is an internationally disseminated program that teaches evidence-based pain management skills to adolescents with chronic pain and their parents. Dr. Coakley is an associate professor of psychology at Harvard Medical School and holds national and international leadership positions. Dr. Coakley's career focuses on translational research of evidence-based psychological intervention for pediatric pain management. For her work in research and program development, she was honored with the 2016 David Weiner Award for Leadership and Innovation in Child Health, and with the American Psychological Association's 2020 Caroline Schroeder Award for Outstanding Clinical Practice. Outside of her academic work, Dr. Coakley enjoys writing and lecturing to help educate parents and providers about chronic pain. Her book, When Your Child Hurts: Effective Strategies to Increase Comfort, Reduce Stress, and Break the Cycle of Chronic Pain, won a National Book Award for the Best Parenting Book of the Year. Her writing is also featured in her ongoing Psychology Today column, The Washington Post, and numerous other publications. So now I will hand it over to you, Dr. Coakley.
All right, thank you so much, Melinda, for the kind invitation to be here. And also so hard to sit and listen to your own bio, always, I don't know. I am delighted to have a chance to share with you the body of work that I work on. We're going to talk a little bit about chronic pain and also, importantly, just about this idea of knowledge mobilization, because in science, this is such a critical gap across the board, not just in chronic pain. And so we'll think about the chronic pain piece of it, but also about translational science and knowledge mobilization in a broader context. So let me go ahead and jump in. And I know that oh, hold on, you don't see it yet. We'll protect some time for questions at the end, but I'm also not averse to people jumping in and asking questions as we go, if you can chat them in or anything like that. So, all right, hopefully. All good? Thumbs up, you can see it? All good, okay. Right, okay, so we're talking about psychology innovations in pediatric chronic pain, and we're going to be talking about how we help kids get back on track once they've become really stuck in a chronic pain cycle. To kick off, just a quick disclosure here. I'm going to be talking about the development and implementation of the Comfortability Program. And this is a clinical program that's now licensed by Boston Children's Hospital. We're running at 26 children's hospitals right now. The license revenue from that comes back to fund the corpus of the program, but there's no commercial involvement in that. But just to be clear. Okay, a couple quick objectives here. We're going to talk about why psychology is such a necessary part of the treatment for pediatric pain. What's the gap right now in clinical care, and what can we be doing to fix that? And then we're going to talk about the Comfortability Program specifically, and what problems it's addressing and how we're moving knowledge through that program. Just to ground you all in sort of the problem that is pediatric chronic pain, it is a massive problem in healthcare right now. And a lot of people are surprised to know that it's 1 out of every 4 to 5 kids will have an episode of persistent or chronic pain that lasts 3 months or more before they reach adulthood. And when we talk about chronic pain, we're really talking big picture here about headache pain, abdominal pain, musculoskeletal pain, and neuropathic pain. Those are the main culprits, but also persistent disease-related pain, post-viral pain, post-surgical pain, post-injury pain. All of that gets lumped together when we're talking about these longer episodes of ongoing pain. And not only are kids struggling with the pain itself, but of course there's a ripple effect here. 80% of adolescents have problems sleeping, 90% of adolescents with pain have problems with school. And that's sort of like a blanket statement, right? We're talking about missing days of school, not being able to complete homework, lower grades. We look at sort of impact of school at that sort of functional level, big picture. And then these kids are 2 to 3 times more likely to develop anxiety and depression as compared to those without pain. And that's pre-pandemic. So even in the context of what we have going on with COVID, where mental health is such a crisis in adolescents, this is making it even worse. So we have this really enormous problem on our hands. And to complicate it even further, not treating pediatric pain leads to worsening pain in adulthood. So we know that the longer the pain goes on, the more entrenched the problems become and the harder it is to treat. That 35 to 73 you see there on the screen, that's the number of kids that end up with persistent pain in adulthood. And this matters in terms of like what diagnosis you're looking at or what persistent pain problems. So like migraine headaches are one of the biggest culprits, but we have all sorts of musculoskeletal pain as well that persists into adulthood. So you get this sort of really complicated problem. And when pain persists like that, it's not just that the single pain problem goes on, but over time, the whole nervous system it changes. And when there's persistent pain, becomes more sensitive to pain. And that sets people up for more disability and secondary and tertiary pain problems as well. So it's really important that when it's diagnosed and identified in adolescents that we get it treated. Historically, the healthcare system in general has done a terrible job in treating pain. Physicians get very little education about chronic pain management. And there's this sort of, biomedical divide that historically it wasn't real pain, or if we can't see it on a scan or we can't treat it with our medications, it must be a psychological problem. Or physicians might say, we're not sure what's going on. This doesn't fit any clinical picture that we know. And also, we don't know how to treat this, which of course induces a lot of fear and panic in kids and their parents. I do think, by and large, we really have moved into this more present-focused approach where we understand that pain is real. We know that it's a protective function of the nervous system. We know a lot about how to treat it. And we're very hopeful, especially in pediatrics, that this is going to get better. We see it all the time. So that sort of shift, I've been in the field about 15 years. I've seen it even in my colleagues. I've seen it in all of the institutions that I work in, but it's slow going. It's like a molasses kind of shift. And even within institutions that are doing a pretty good job of identifying and treating it, there still remain providers that really don't understand this whole biopsychosocial picture. With that in mind, treatment of persistent pain always requires a multidisciplinary kind of approach. Pain is always a psychological and physical experience, and we have to treat it from all angles. The way I often explain this to kids and to families is to say that when you've got chronic pain, you're like a tricycle with 3 flat tires. And in order to get you going again, we have to fill all of the tires. We use medications maybe for 1 tire. We have to use physical activity or structured physical therapy for a tire. And then the strategies that we teach through cognitive behavioral therapy as well. We don't fill all of them. You end up just spinning in circles. And if you fill 1 tire, like say with medications, and that doesn't work and you stop it, and then you fill another tire, say with physical activity, and that doesn't work, you end up still not going anywhere. So to get that traction to go forward, we really need this sort of group approach. And one thing that's often overlooked is that parents also need intervention here. 75% of parents report that they don't know how to help their child with pain. And so many families that we see at our specialty pain clinic report that they have already gone to see so many specialty providers, had so much testing done, had so many medication trials. It's time intensive and very costly for families to go down this road. And it's not necessary a lot of the time. I mean, yes, of course, we have to rule out all of the bad, scary stuff. But once that's done, we need to more quickly shift to this multidisciplinary approach so we can start to rehabilitate kids, because there's great harm in waiting too long. The kids and the parents get a lot of fear around this whole evaluation process. And during that waiting period, kids often get much worse functionally while they're waiting to find out what's wrong. So why does psychology matter so much in the treatment of persistent pain? Well, pain is always physical and psychological. You cannot tease them apart. The whole experience of pain comes from the brain, and they are always tied together. Chronic pain impacts all areas of a child's life, like we talked about sleep and mood and school, friendships, all of that. We know that the emotional responses to pain impact recovery. We have decades of evidence on this, so we don't need to study that anymore. We know it's true. And also another thing that we can really hang our hat on is this idea that caregiver language and behavior impact recovery. This is not blaming parents. This is not saying it's their fault. But when parents are very fearful about what's happening with their child, or when parents become overly focused or hyper-focused on the pain cycle, or when they catastrophize what's going on with their kids, it makes it worse. It sort of doubles down on the amount of time it takes to recover. So we have to treat the parents too. Okay, I'm assuming that most of you know what cognitive behavioral therapy is, but just as sort of a refresh here, an evidence-based type of psychotherapy, it's based on our understanding that thoughts, behaviors, and emotions are linked together, right? That's the mind-body connection. And it focuses on identifying problems, learning new ways to approach or manage the problem, and tracking improvement. It is the gold standard of treatment in psychology. It is evidence-based across the board. We use it for lots of things, not just pain, anxiety, depression, stress management, all of the above. But specifically with pain, when we talk about pain-focused CBT, we're talking on reducing the severity and frequency of symptoms, lowering stressors that might be amplifying pain syndromes, improving daily function is a big focus because we know that kids function better before they report that they feel better. So the function part comes first. And we know that it reduces symptoms of anxiety and depression as well. And then importantly, sorry, the last one, improves self-efficacy. So this is the idea that pain is manageable and that as a patient, I could do something to change this situation. So when you think that the situation is completely out of your control or you're just a victim to your pain, that sense of hopelessness and helplessness amplifies pain cycles. So we really want to work on developing and improving the sense of self-efficacy and arming people with the skills that they need to manage their symptoms. And so when we think about sort of this family piece of it, I want to highlight that the recovery from pain is not intuitive. It's not at all what you think. And especially when kids and parents are stuck in a chronic pain cycle, some of the first things we have to teach them kind of make their brain explode. They're like, are you kidding me? So for kids, we have to teach them this idea of function first. Increasing your activity will help you to feel better. That makes no sense. That's not how acute pain works. And so that's very confusing for kids to understand. We also have to teach them sometimes it hurts, but it's not harmful. We teach them that getting back to school, getting back to their routines is an early part of how we reset these pain cycles. And we teach them about this idea that thinking about or focusing on that pain makes the pain worse. And so we need to learn how to shift out of those cycles. On the parent side, we have to teach them that letting your child rest too much can lead to more pain. So when kids rest in response to their chronic pain, they get deconditioned, they focus on the pain because they're not doing things, their life sort of becomes very small and very hyper-focused on the pain. Doting on their children, sort of all of those loving parenting behaviors that you do when your kids are sick with like strep throat or a cold or something like that. All of those behaviors, when they stretch out over many months, actually amplify pain cycles. Talking about pain a lot with your kids makes it worse, so we have to teach parents how to connect with their kids around some other kinds of things, so that's not the only thing they're focused on. And setting goals and helping to keep their kids accountable to reaching those goals is an important way that parents can support their kids. So all of these things we work on from the psychology end, and just putting a kid in physical therapy or giving them a medication doesn't teach them this bigger picture of how we actually recover from the persistent pain. The other thing that's really important with pain, different from other things we treat in healthcare, is that it's very individual. It's 100% subjective, always. There's no way we can measure it other than asking. And we have to take kids at face value when they say that they hurt, that is the truth. And so we can look at these pictures of all these kids, any or all of them could have persistent pain. Often they don't look like they're in the pain that they report they're experiencing. So it's very easy to invalidate their experience, but invalidating that can make it worse as well. So we have to always be thoughtful about this idea that kids feel pain differently, they express pain differently, cultural norms come into this. There's so many things that influence the experience and the presentation of pain. Okay. So let me break down, we sort of talked high level about how psychology helps with pain, this idea of CBT sort of at that broader concept here. But I want to unpack for you a little bit about what we're doing in psychology that really helps with persistent pain. So I want you for a minute, we're going to talk about two ways that psychology can really help with persistent pain. And I want to just sort of introduce a couple metaphors here to think about this. So the first metaphor is sort of this idea that many of the strategies we teach in psychology work like dimmer switches on the electrical system. So think about them dialing down pain sensitivity. These are all of our relaxation-based strategies: breathing techniques, guided imagery, mindfulness, biofeedback. All of these things really work to dial back that pain sensitivity. So if pain is an activation of the nervous system, these are sort of cooling off that nervous system or dialing back that sensitivity. They also help to reduce stress, and that helps to settle down the nervous system as well. That's one group. Here's how it works, right? So kids have high pain. Pain is 100% of the time processed in the brain. They might use belly breathing or diaphragmatic breathing to start to relax a little bit. That might dial back the pain sensitivity. We might pair that with a guided imagery where they're, taken using a very sensory-rich story to create that sort of as-if effect with the imagination, and that helps them to lower pain even further. So we're helping them to sort of dial back that sensitivity, and we have to teach these strategies. They have to practice them to get good at them so they have confidence that they can use them when they've got persistent pain. Another group of skills I think of more like circuit breaker strategies, and these are really the behavioral changes that we want kids to make to get off that cycle of high pain leading to rest, leading to more pain. So think about these as structured approaches that help to reset sleep patterns, activity pacing to help improve physical activity, return to school plans to help kids get back on track at school, those kinds of things. And so here's how these work. I think of pain a lot like a habit for the body over time, this persistent pain, and here's how the habit cycle works. High pain leads to resting and stopping activities and withdrawal from friends. So that creates a lot of negative thoughts, like this pain is ruining my life, which leads to negative feelings. sadness, worry, helplessness, which leads to even more pain, and on it goes. And so we have to think about what can we do to break that cycle. And on the psychology end, we're really working at breaking these cycles where we're at this point, 2 places here, the behavioral change and also the thought modification. And so when we do that, it can look like this. High pain leads to starting small and using a steady, even pace to build back function, which leads to a modified thought. This is tough, but I'm learning to manage my pain, which leads to more positive feelings, which leads to less pain. And we think about this and we teach this as sort of breaking that loop that's on repeat for these kids and families. So those are our circuit breakers. Okay, that's the backdrop to this work that we're doing. So when we talk about sort of this evidence-based in psychology, I want you to sort of understand that we're coming at it knowing after decades of research that these things work really well. Like we know how to reset these cycles. And the problem is this knowledge mobilization gap. We know that integrating psychology into pediatric chronic pain reduces an over-reliance on medication and opioid risk, improves functional ability and reduces pain, and decreases that long-term risk for persistent pain and functional disability, and also billions of healthcare dollars. The challenge we face is they're underutilized. These psychological strategies are vastly underutilized in the treatment of pain, and many families don't have access to service. There is still, of course, mental health stigma that is an umbrella over all of this. People don't want to go to a psychologist for what they perceive to be a physical problem, and so there's a gap in education, but also that stigma that we have to address. And there's lack of knowledge about efficacy. And this is on the patient front for sure. Like parents and kids don't understand how psychology can help with chronic pain. That checks, like that's not common knowledge. But there's still a lack of knowledge on the provider front as well. And so providers often don't have the language to talk about this. They don't have referral places to send people to get these skills. And so there's that sort of big gap in care here. And that's really where the comfortability program comes in. So this program was developed to teach kids and parents proven skills to manage chronic or persistent pain. This program is not recreating or developing or trying or testing a brand new intervention. That's not what this is about. This is a knowledge mobilization problem. This is how do we take what we know and get it to the people that need it in a really responsible way that makes it easy to roll out. And so that's the gap that we're trying to fill. And so as I talk about sort of how we developed and disseminated this work, I want you to think a little bit about whatever area of research you're in, what you're doing, because this is a framework for how we mobilize knowledge is what we're doing here. So here's our mission: teaching kids and their parents the evidence-based psychological tools to manage chronic or persistent pain. Our goals in this program were to engage, educate, support, and empower families. So we want to really teach them what we're doing and get them really engaged in this idea of using psychology alongside the other interventions they're using for their pain. Our vision: reduced disability and comorbidity associated with persistent pediatric pain by enhancing access to care, improving parent and child self-efficacy, so this belief that they've got a role to play in managing these symptoms, and connecting them to science-backed resources. So that's what we're doing. Importantly, in the program, we're very focused on getting this information and knowledge and skills training to parents and to patients. And also from the ground up, this has been designed for widespread dissemination. So in parallel with thinking about what do we want our patients to know, we're thinking about the systemic professional training and transfer piece of this and the procedures, and they're a fundamental part of the program. So the work that I do is really the program dissemination, which is all about professional teaching, training, fidelity management, all of that. and the assets that are going out to the kids and to the parents. The ongoing connection to our CAP network, which is our network of sites that we use now, promotes a reiterative knowledge mobilization process. So as we roll out, we're always learning and doing better, finding what's working in different sites, thinking about the rollout through various healthcare systems, clinical pathways, all of that is a part of what we're doing here. So right now we have partnerships through the United States and Canada and Australia. We've trained over 200 providers to deliver the intervention. We've treated over 5,000 patients. So the reach that we've had through our dissemination phase, which has been about 6 years, is growing, and it's expanding really quickly. So let me just show you sort of how we're doing what we're doing. This is called the knowledge to action cycle. I didn't invent it. It was described and sort of talked about in the knowledge translation literature. Graham et al. This is a modification of a model that was put out by Graham et al. In 2006. And I know it's busy, so let me just give you a sense of what we're talking about here. Okay, look with me down here in the orange #1 section, which is where all research starts, right? Like looking at identifying gaps in knowledge and care, but also looking at access barriers and practice-informed solutions. So what's reasonable, what can reach parents and kids, how do we work into clinical pathways? #2, generating the knowledge and assets and developing local implementation procedures. And #3, evaluating clinical and systems-based processes and refining content. So this generation phase, phases 1 through 3, was about the first 5 years of this project, where we really kept piloting and tweaking and developing until we had assets and research to support something that felt really sturdy. And then we moved into the dissemination phase. So that's phases 4, 5, and 6, developing and testing implementation procedures with a shared focus on the institutional and provider experience. So what feels possible, what works well, what's easy to implement at the systems level, all of those kinds of things. Then expanding clinical and institutional and patient partnerships and building enhancements. So as we grow, expanding what we've got to share through the network, and then monitoring and sustaining knowledge use, building network relationships, and continuing innovation. All of those are part of the development process. And in the center here are the CAP, Comfortability Program assets. So we're talking about workbooks and leaders manuals and comfort kits, our training and administrative protocols, the website, which really houses a lot of evidence-informed content for us to make easily accessible. We've got advisory boards, patient and parent, that help to inform the work as well. And then really management and staying connected to our provider network, because then we get smarter and stronger and sturdier at what we're doing and continuing to grow. The guiding principles for the comfortability program development have really been, how do we maintain fidelity? So if we're really doubling down and spending years on putting together an intervention that is really aligned with our best knowledge base, like the gold standard of what we know collectively from the research about the psychology of pain management, how do we roll it out and be able to expect similar outcomes at all of the sites that are running this? So that fidelity piece of it is really important. At the same time, how can you be flexible enough? You know, we think about double-blind, placebo-controlled studies and the sort of control needed to really effectively test things. And then we have to think about real-world implementation. Like, how can you be flexible enough in the work that you're doing so that it works for different providers through different healthcare systems so that you can spread what you're doing? And then how do you help it to stay sustainable? The BCH, the Boston Children's Hub, has to be able to sustain it. This is why, in part, we take revenue from these licensing fees. That's part of our revenue stream, because we can't be just on soft money, just on grant money. and then for our partner sites as well. I'm mindful of the time. I want to protect things with protect some time for questions to talk about this systems level work, but I'll just tell you really quickly what it is that we're doing at the comfortability workshops. What are we spreading? 4 core principles. One is psychoeducation, so really teaching kids and families, why does psychology matter? How does pain, how do we use these CBT skills to really manage persistent pain? And that, of course, ties in to pain neuroscience education. So we teach them the biology of how pain works, how the tissues of the body aren't really producing the signal of pain, that it's coming all of the time from the brain. We teach about how the limbic system is involved in the fight or flight response and the memory that you have about painful events and how that influences pain. They have to really understand that neuroscience piece of it, or they don't understand why psychology matters. So we tie all of that together and teach it developmentally appropriately to kids ages 10 to 17, as well as to parents in separate groups. And then they get hands-on skills training. So we don't just tell them what to do, but they're practicing in vivo in the workshops through the program. And then all of the comfortability work is done in a group format because social support is so important. And we know that from our research. So if we can help people connect to each other, if they learn that they're not the only ones struggling with this, they're going to do better. The evidence-based content that we're building on is different for the adolescent and the parent group. We use in both of the groups multi-method learning. So they've got written workbooks, there's some didactic instruction, there are interactive videos, there's in vivo skills practice. And in the adolescent group, these are the things that we're really focusing on because this is our strongest evidence base. And in the parent group, you can see we've got a sort of a different group, but there's some overlap. So the programs are not the same, but they dovetail with one another. So that's sort of what we're going through in each of the programs. And right now we have 3 different programs that we're disseminating. One is an in-person workshop, which was sort of the first iteration. And then we also have a telehealth workshop as well that's rolling out. And then we have a separate workshop that is for kids with sickle cell pain, because that's a really unique population that has different access barriers or additional access barriers. And because it's a population where healthcare equity has failed for so many years. And so we really wanted to create a resource that was specific and could help to improve healthcare equity there. And then we have other workshops and other assets that are in development as well, including a module or a workshop that's going to be for kids with cancer-related pain. And then we have a professional training portal, advisory boards. We have booster content that comes through our portals as well, and then ongoing collaborative research through our network as well. The in-person workshop runs in a 1-day format. It's an all-day thing, 10 to 5, and the kids and parents, as I said, are in separate groups. I will say that this, of course, took a hiatus during COVID. Many of our sites are back up running their in-person workshops. Some are sticking to the virtual program right now as well. But that runs. The virtual workshop, we break into separate sessions. So the kids group is run over 4 telehealth sessions, and the parent program is run over 2 telehealth sessions. I will say, actually, just back it up 1 second to say that we often run these, many of our sites, including Boston Children's, run this workshop on a weekend day so that it's even more accessible to kids and families, because that accessibility barrier is really important. So this is our virtual workshop. This is our sickle cell workshop as well. And this has even more flexible platform for delivering it. It can be done on the inpatient side, it can be done outpatient, it can be done through telehealth. So lots of assets there and lots of flexibility. I think always in this work that we're doing, yes, we're interested in spread, but we're always coming back to our patients. And I think we think about, in a brief intervention model, which is what this is. So it's, as a package, it's 12 hours of intervention, 6 for the kids and 6 for the parents. And even in that brief amount of time, we feel like we really see the shift in families. And we hear this all the time in our qualitative research, also just in feedback that we get. But parents say things like it was finding a guide in a maze of confusion in the beginning of starting to find positive ways forward and out of the dark hole we were in. We teach parents, we don't just give them a plan, but we teach them how to make a structured plan for return to function. Then they can use that over and over again. So we see things like our child continues perfect school attendance. It's not always perfect, but better since the program, despite headaches. We love the scaffolded plans. They seem to be our lifeboat. For kids, we really hear that connecting with the other kids is really important for them as well. This is just a snapshot of the hospitals that are part of our network presently. And this is even a little bit outdated. Sorry, we have a couple that we haven't added in. But this gives you a sense where through the US, a few sites in Canada, and a growing base in Australia as well. Okay, just to wrap up then, I'll just say that this, it's a joy to be able to present this body of work, but it is not mine alone. I don't know why their names aren't all popping up, but I have an amazing team. Dr. Simona Bugerano, Dr. Amy Hale, they are my clinical leads on this program as well. Janae Biggs is my program manager. Carolina Donato, my bioinformatician, and Dr. Bobby Riley is our medical consultant on the team. This is our advisory board, who are amazing people. They've all come through the program and now they serve on the board to help inform our work. And then also indebted to our department and to the whole network, which is an active part of this research and the clinical development. So some references here just so you can have them for the slides. And that is it. And hopefully I have a couple minutes then to chat with you all and answer some questions. So thank you all for your attention. And I don't know, Melinda, if you want people to chat questions or if you would prefer to just have people in a conversation.
Yes, typically, well, first, thank you, Dr. Coakley, for that great presentation. And typically you could put your questions in the chat or you can just unmute and ask them right now.
Good morning. This is Kevin Domkowski. I have a quick question for Rachel. Thank you for that. Very interesting. I have a question about keeping the fidelity to the program. You're expanding. It sounds like over 25 sites, which is terrific. How do you folks do like ongoing, sort of formative evaluation, outcomes evaluation, and in particular, to make sure that all of your success stays sort of on pin with fidelity to the program? How do you guys do that?
So a great question. So when we uptrain a site, when we get a new partner site, they get a lot of front-loaded training. Some of it is, on demand through our professional training portal, but a lot of it is meetings with us and talking at the systems level and then at the provider level as well. When a site launches, they always have a CAP trainer there to do a fidelity check on their launch at the time. And then there's a follow-up meeting where they go through a report about what went well. If they don't pass, they have to have another fidelity check. So we make sure that at the time of the launch that they really do have high fidelity to the program itself. There is a renewal process every 3 years. So a site license lasts for 3 years. At the end of the 3 years, when they renew their license, they go through another fidelity check to make sure that there's not drift. And then in between, we have a consultation forum. So, we are in contact with our sites every month. They can join to talk about, sometimes it's a clinical issue, sometimes it's a systems level issue like, billing or recruitment or things like that for the program. So there's, ongoing connection to our sites as well. We don't require outcomes research from our sites, although we have several partners, and we have a multi-site study going right now with CHOP in Stanford, looking at in Alberta in Canada, looking at outcomes for our virtual program. Anytime a site wants to do research, we give them, as much help as we can to get it up and off the ground, because we really do want sites to do their own research and look at their own outcomes. But because the pathway in is a clinical intervention, not every site is set up to do their own outcomes research on it. So we use the fidelity monitoring process to make sure that they're staying aligned to the program, and then we just support them in doing research as much as possible.
Great, thank
Okay. We have two hands that were raised. So David, you can go ahead and ask your question. And then I see you, Julia.
Thank you. Thank you very much. Very interesting presentation, and following up on Kevin's questions, very practical. I'm also interested in high fidelity dissemination of programs. How much do you charge a site to be licensed? Because sustainability, you can't rely on grants, obviously, as you pointed out.
Yeah, so we use a model where our licensing fees are tiered according to the size of the hospital, which makes it easier for smaller institutions. And then we also have, so we've got 3 different tiers for our licensing and training. And then we also have sort of what we call a tier 0, which is a site. So for example, a community health site in Texas that serves a primarily rural population is interested to roll it out, and they've got the staffing. We have to make sure that it's got good staffing and systems level support. But for a site like that, we're able to slide on our licensing fees so that we can make it more accessible. So, it's a model where the bigger sites that have more resource pay in a little bit more to be a part of the collaborative, and then the smaller sites have a little bit of an easier access point as well.
Are you hesitant to say what the range is?
No, I'm not hesitant to say. Well, I will say this: it varies. So there's the licensing fee, and then there's the training fee, and the training fee changes depending on whether you are getting trained just on the in-person workshop, or getting trained on the in-person and the virtual, or the sickle cell. So how much training your site needs shifts. So I can't really speak to that because that's done sort of individually, but the licensing fees start at, you put me on the spot. Wait, I have to look it up, but I think that they start at $5,000, and I think they go up to 20.
And that's annual?
No, that's every 3 years.
Every 3 years.
The implementation, like from the other thing, from a fidelity standpoint, we always have a psychologist who is the site director for the program. So this is somebody who already knows CBT, who is already, embedded in a pediatric healthcare system, understands this sort of skill set. So we put it in the hands of somebody that we already know really fundamentally understands what they're doing with it, and can also help us to monitor that as well.
Thank you. One other question about say when you do your virtual sessions, you're billing for the service?
Yes.
And so that means that the person needs to be in state according to your licensing? Is that correct?
That is true. That is true. We do have, I think with all of the emergency orders doing telehealth, at first when COVID hit, we could pretty much see anybody. But now we're sort of coming back to the new normal. In New England, we're seeing that there are a couple neighboring states that allow us to do telehealth across state lines. But we have to sort of make sure that our license, there's the insurance piece of it, and then there's also like where you licensed and covered that way. So when those stars align, we will sometimes do telehealth, in a broader context that way. But you're right. Most of it is, within the state. Even still, we have many families that live within Massachusetts, hours away, that it would be hard for them to get to the hospital to do the workshop in person. So the virtual one makes it more accessible.
Thanks very much.
Mm-hmm.
Okay, Julia.
Yeah, so thank you so much. I noticed that the program is mainly geared towards, I guess, preteens and adolescents. Have you thought about expanding to a younger age group? And if so, what types of barriers do you foresee?
Yes, we definitely have thought about it. And it's sort of one of the projects that keeps getting pushed to our back burner. I do think we could do it with younger kids. So it's ages 10 to 17. I think it would be a shorter day. And I think we would do, the sort of model we would use is to have probably kids and parents together. So it would be a little bit of a shorter intervention, but we would have parents really helping to support their child's practice and learning the skills as well. So I think just the developmental piece of it would shift. In the 10 to 17-year-old group, we're really trying to empower these kids and arm them with their own skills and strategies, which we want to do for the younger kids as well, but they'll need a little bit more hand-holding from mom and dad or whoever their parents are to be successful with that.
Okay, and Toby?
Yeah, hi, that was a really great talk. Thank you so
Yeah.
much for sharing that. So I had a question related to the sickle cell and, well, it came from the sickle cell population, but I think it applies to other populations. So there's some situations where the chronic pain does not have an identifiable organic source. And there are other situations like sickle cell, or I can think of migraines, or maybe inflammatory bowel disease, where there is chronic pain, but there is also an organic source that potentially you could address some of the pain by dealing with the organic problem. And just question how you deal with the messaging there, because sometimes it's, okay, the pain's there, we've got to learn how to function, we've got to learn how to decrease your sensitivity to the pain. And sometimes it's you need to go back to your neurologist and get a different migraine medication. And like, how do you navigate that in your messaging?
Yeah, great question. I think this is really where we come back to that multidisciplinary model, right? We never say your pain is psychological, so you need to use this bucket. But we're always, working sort of with hematology, with neurology, what part of this can we manage? The messaging, the language is so important around this. And I think, we don't talk about what's organic pain and what's not organic pain, because that does not matter. That actually does not differentiate our populations. And in our research, it doesn't matter. Like when you look at sort of improvement in function, the kids that have in the program, we have kids with headache pain and abdominal pain and musculoskeletal pain and disease-related pain. They can all come together because these skills really work on that brain-based, on those brain-based strategies. What we're talking about is not getting rid of pain. What we talk about in the program is what can you do to boost your comfort? How do you get yourself more comfortable? What's within your power? What's within your control? And many times, even for our kids with sickle cell, they've got a really clear plan from their hematologist. Like, these are the medications you have access to. If you're moving into a crisis, you need to use your heating pads, you need to use your medications, and you need to use your comfortability skills. Like, those come together in a package. And with that, we hope we avoid a hospitalization or an escalation in a crisis. So I think, but always, like, when do you know, like, when do you have to go back? Like, how do we monitor this? We never make kids bulletproof enough that, things could get much, much worse and they wouldn't notice or they wouldn't think about going back to a doctor. But we just give them the skill set that they need so that their functioning doesn't get worse, that they can stay connected to their life. Like that's so, so important, no matter what the underlying issue is. Does that make sense to you?
Yeah, no, I'm going back to your analogy of the tricycle. It's like you got to do it all at the same time.
That's it.
And it's a package.
It's a package. It's a package. And this is the part, like in our research, we looked at, we always recommend when kids come through a multidisciplinary clinic, they get evaluated by psychology and physical therapy and a physician. And we always recommend, this is how we sort of put this together. But we looked, like 10 years ago, we did this research project. We're like, who's following up on what? And, you don't have to be a rocket scientist to figure out that, like, Most of the kids followed up with their medication. Most of the kids followed up with their physical therapy, and a measly amount followed up with the psychology recommendation. So we're like, just sending them out to a community provider. Number one, they're not getting the targeted skills they need. Two, they couldn't all come back to our pain service to see a psychologist because of travel times, because of, we don't have enough pain psychologists to do the work. So we were like, we need to do something here. This is totally lagging, and yet it's an essential part of the recovery.
Well, thank you again, Dr. Coakley,